Now let's discuss labor. Labor usually begins between weeks 38 and 42 weeks of gestation. Anything before 38 weeks is considered preterm labor. There are certain signs of labor, but not all of them are specific to true labor. So some signs of labor are a bloody show, and that is when the woman has a blood-tinged discharge. A burst of energy, also called nesting. Rupture of membranes can happen before the onset of labor, so it is indicative that labor should be happening soon. Lightening, or a feeling of the baby has dropped. Contractions, cervical changes and effacement, and then dilation. We're going to have to decide which signs of labor are true labor or false labor. True labor has contractions that are at regular intervals. They get stronger and more intense, and they increase in duration over time. So that means the contraction lasts longer and they come more frequently. Discomfort starts in the back and then radiates to the front. So their pain usually starts or it starts in the front and radiates to the back. So either way, you have some back pain with their contractions. True labor is the only one that causes effacement and dilation. So dilation is going to be your true indicator of whether or not a woman is actually in labor. The contractions will intensify with walking, whereas with false labor, if they stop walking or they take a warm shower or a bath, the labor pains will go away. So with true labor, if they take a warm shower or a bath, or they lay down to rest, the contractions do not go away. False labor is irregular contractions. Sometimes they can be regular for like an hour or so, and then they'll just stop, or they'll be very irregular after that. So it's not always 100%. They do not increase in duration, so they don't get longer. They do not cause dilation. They do go away if they rest or take a bath, and they do not intensify by walking. So sometimes if someone thinks they're in labor, the nurse may say, hey, go take a walk and see if they get any stronger or if they start to change. There are 7 P's of labor. Some texts still say 5 P's, and some texts say 7. It's not that important. It's just a nice way to help you remember the things that affect labor. The passageway, the vaginal canal, the passenger of the baby, the powers, the muscle strength, the psyche of the woman, position of the woman, the position of the baby, problem areas that influence labor negatively, and then pain, of course, affects labor. There are soft tissues in the passageway, mainly referring to the vagina and the cervix. Early in pregnancy, it's firm, long, and closed, about 2 centimeters long. Closer to delivery, the hormones start to change it. It starts to soften up, it gets shorter and thinner, and it's measured in percent. So 1 centimeter long is 50% effaced. So effacement is measured in percent, and the shorter that the cervix becomes, the more effaced the cervix is. So if the cervix is only 1 centimeter long, it's 50% effaced. The practitioner who is measuring can actually wrap their finger around the cervix to see about how long it is. So that would be effacement. Dilation measures in centimeters, and it indicates the cervical opening. So effacement is how thin it is. The dilation is how wide it's becoming, how much it's opening from here to here. Effacement usually starts first, so usually the cervix has to thin out and get really nice and thin, like in picture D over here. It has to really get nice and thin before it can actually start to separate and dilate. But in multiparas, it can happen pretty quickly, all within the same time frame. And it's normal to dilate 1 to 2 centimeters weeks before you even begin labor. So the vagina, it stretches and smooths out and is very soft. The fetal skull is considered a part of the passenger. The passenger is really the fetus. It's the most important in relation to labor and birth. That baby has to be maneuvered just right to come out easily. Molding of the fetal skull is when the bones overlap. So their skull has sutures and they're not fused. So here you can see a suture. And during the birthing process, molding happens and it will overlap on top of each other. So this is why the sutures are not fused, so the skull can mold and come out and have little cone heads. Here we see a picture of the infant's sutures. So there are sutures here. Here you can see the sutures, and then we have fontanelles. So this is the front of the baby's head here, and they have this larger fontanelle, the anterior fontanelle. It's an open area where the bones can overlap, and then there is posterior fontanelle, which is a little smaller. So this is important when they're doing cervical checks. They can feel the top of the baby's head and feel where these fontanelles are and where the suture lines are, and they can tell the position of the baby's head within the pelvis just by feeling the fontanelles. The next part of the passenger is the way the position of the baby is lying, so the fetal lie in presentation. Fetal lie can be longitudinal, transverse, or oblique. So longitudinal is an up and down position. This is the one we really want them to be in, is a longitudinal lie. Transverse is when they are lying horizontal. That's not good, and that's a baby that can't be delivered that way, has to be C-section. Then oblique is when they're just kind of a little like this, like an X almost. So they're that way or they're either this way. That would be oblique. They're just kind of a little off course for which way they're going to come out. The fetal presentation is which part is presenting first. So presentation, present. So which part presents first. Cephalic. This A picture down here shows a cephalic head down baby. Breech is either usually the butt for breech. Then there's a shoulder lie, which I don't have a picture of shoulder here. And then a footling breech. So C here is a footling breech. A is considered like a frank breech where the legs are straight up in the air. And then B is just your general breech baby coming out butt first. So both of these babies would need extra care. The next part is the fetal attitude. And I like this word because it's like, which way you cocking your head at me? So what kind of attitude does this baby have? And there's different ones. There's only really 4 different ones here that we're going to discuss today. But the most common, the most one we want to have is a fetus who is fully flexed, and we call this the fetal position. They're all balled up, chin on their chest, their back is round, they have their legs flexed into their abdomen, and there's different ways that their head may be flexed. We really want it to be down with the chin on the chest, right? So another one is flexion, vertex. That is the same thing as this. So we want them to have a vertex position. Their head is down completely, and they have the back of their head is presenting first. Military would be there's no flexion or extension. Their neck is like straight. So their neck or chin is not down on their chest. It's just looking straight. Brow is when that's obvious. The forehead is coming out first. And the face would be they're presenting with a face extension. So let's take a look at these pictures here. So which one do you think A would be? Right, that's our most favorable flexion. That's the one we really want, is A. We want them to have their chin on their chest and their knees are flexed. They're looking great. Okay, B, we can kind of see that there's not much flexion here going on. The baby's kind of looking straight out. That's going to be our military military pose there. The next one, we have some hyperextension here a little bit. And then down here, we can see the faces over and towards the pelvis. And then we have some of the forehead here. So that one's going to be your brow presentation. Then with the last one, you can tell there's a lot of hyperextension of the neck here. And then we have pretty much, if this is part of the canal here, we have a facial presentation. So that means the baby's occiput is facing mama's left side of the posterior pelvis. So the baby's head here is facing mama's left side. So this is the left side of mom. This is the right side of mom. It's facing the left and to the back. You can see the baby is facing forward right here. So it's going towards mama's back left side. So the occiput is facing the left side of mom's posterior pelvis in a 3D sense here. So it's left occiput posterior. Now, this is just a little more information on how these things are done. Now, it can be different presentations, and I'll just say that we don't have to learn every single one. We'll just learn the vertex positions for when the baby's occiput is down, and that will make our lives a lot easier. Maternal pelvis is the 4 quadrants we just talked about. Remember, I talked about the left occiput posterior. Okay, so let me see. My most common position is LOA, left occiput anterior. We want the baby's back to be towards the front of the mom. So when you're filling the Leopold's maneuver, you want the back to be up there. We want the baby to come out nice and flexed, and then have an easy way to push out the baby, because the force of the contractions is coming from the front here, So it's easier to push down and let the baby slide out this way. So LOA is the baby's occiput is to the left of mom's front of the pelvis. This is the front of the pelvis, the back of the baby's head. So left occiput to the front anterior. So left or the right, either way is a most favorable position for a baby, LOA and ROA. With like these other ones, the baby has to do a little more rotating. They have to rotate inside a little more and maneuver a little more to get their shoulders through these pelvis bony promises and stuff. So their shoulders have to kind of wiggle through here. It's easier to wiggle through with the ROA and LOA. Looking at it one more time, there's other reference points. So maybe the baby's occiput is not presenting, but maybe it's the brow, and they may have an F there instead of an O. So it just depends on what's going on. Or maybe it's a breech, so the sacrum is presenting first. But the main things you're going to be questioned on and they want you to know are these two, ROA and LOA. So if we look at ROA, the baby's occiput, we can see that it's facing the anterior part of the pelvis, the front, not the back. It's because the face is the opposite direction, so you can see that. So we have and it's facing mom's right, mom's left. So it's facing mom's right. Occiput is the one that's here, and then the anterior part of the pelvis. With fetal station, it's fun. I don't know why. It just is to me to see this drawing in the 0 station, and it's just fun. I've done some vaginal checks on women in labor when I worked in labor and delivery, and you can really tell where those ischial spines are and how high the baby is and how low the baby is. So it was kind of part of the easier parts of doing the vaginal check. So a zero station is the presenting part is at the level of this ischial spine. So these little protruding parts here are the ischial spines, and that gives us our landmark. So if the baby's head is here, they're at a zero station, right? Of course, I kind of drew it a little lower, but that's okay. So here we go, zero station right here. Anything that is above it is considered a minus. So minus, 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 minus. So this baby is at like a -2 here, and then -4 would be up here. So above it, it's going by centimeters. So the baby's -1 centimeter, -2 centimeters, -3 centimeters, -4 centimeters. And the plus station is how far below the ischial spines the baby's head is. So we say a 0 is pretty much engaged into the pelvis, and anything above that is bringing the baby closer to delivery. So +4 would be a crowning for delivery. So question, a station of -1 means that the fetus is very close to delivery, the head is passed through the ischial spines by 1 centimeter, the head is at 1 centimeter above the ischial spines, the fetus is unlikely to be born vaginally. Okay, correct answer is 3. The head is 1 centimeter above the ischial spines. So negative, above. They're not coming out, they're still in. So -1 above. Another critical factor in labor is the powers. So we're talking about uterine contractions here. The increment is the increase, the acme is the climax, or at the very top of that contraction. The decrement is the contractions going away. There are other terms used to describe the contractions: onset, duration, frequency, and intensity. And we'll teach the patient how to time their contractions. Okay, let's take a look at it here. Here's the contraction. The building up of the contraction is the longest part of the contraction. So we're going up for the contraction. It's kind of what it looks like on the strip, the little hills. The acme is the peak of the contraction. And then the decrement is on the way down. So it's kind of the uterus is starting to relax. Then when it gets all the way relaxed, we call that the relaxation phase or period. And this is a very, very, very important period when the placenta is going to get reperfused with oxygen. So as the contraction is happening, it's kind of clamping off blood vessels and squeezing them tight. The baby can be without oxygen for a short period of time. So they need the relaxation for the placenta to reperfuse and regenerate some oxygen to get to the baby. Here I have some pictures of what the woman might look like during her contraction. So here she feels it coming on, it's getting strong. Acne, oh goodness, it's super strong now. Oh, it's gone. This is what the typical woman looks like in labor now. Checking Facebook, checking up on her friends, letting everyone know how things are going, and that's kind of how it is now. The frequency of a contraction is how often they happen. From the beginning of one to the beginning of the next. How frequent are they? Beginning to beginning. Duration, how long does it last? Beginning of the contraction until it goes away. That one contraction, how long is it? Intensity, how strong is it? The nurse can measure the intensity of the contraction by placing her hand on top of the fundus to feel how hard it is. A really strong contraction feels like the top of the forehead. A mild contraction feels like your chin. In the picture here, we can see how to time contractions. So if you're going to teach your patient to time contractions, we're talking about the frequency, how far apart they are. So how far apart are your contractions? We would tell them to say it's the beginning of one to the beginning of the next. So from here to here is the frequency. The beginning of one to the beginning of the next. Duration is how long it lasts. So it started, that's the onset, and now it's gone away, that's the end. That's how long. Usually around 60 seconds is the average length duration of a contraction. And in the interval, there's a pause, so there's no contraction going on here. We need this pause because during this section, there's no oxygen happening to the baby. And in this section, there's a relaxation where we can get some more O2. The intensity is how strong it is, measured by palpating the fundus at the peak of the contraction. It is either mild, moderate, or strong. The position of the woman in labor is very important. We got to use gravity to our advantage. We reduce the length of labor by having the woman in a standing position. That could be walking or just standing and hovering over her partner, sitting on a ball, or just sitting, period, or kneeling with hands and knees. Position is a great position for labor and delivery. It reduces the need for assisted delivery when the woman is either sitting upright for delivery, and that's like sitting straight up, high Fowlers. A lateral or side-lying position is helpful, or a squatting position. In some places, they even have birthing stools where the woman can assume a squatting or a sitting position during birth. Which maternal positions are considered appropriate for labor? Select all that apply. The correct answers are side-lying, sitting, standing, and walking. Being in a supine position decreases the placental blood flow, so we do not want to recommend laying on the person's back for labor. Fetal attitude refers to the relationship of fetal parts to each other. Which fetal attitude is most favorable for a vaginal birth? Is it extension, flexion, military, or hyperextension? Right, the correct answer is flexion. The psyche of the woman is needed to have a positive experience. A woman's anxiety level or her thoughts and beliefs about her birth process can negatively affect her labor process. It can stall the birth process. It can make it more painful. So we have to hone in on our patients and emotional needs during labor and delivery. It can be affected by religious values, beliefs, other people around her, the trust in the healthcare system. We should give information updates, be clear and concise, reassure her and praise her for managing labor, continuous one-on-one support, and assisting her to maintain a sense of control in labor situation. Pain management is important, and we'll talk about a whole pain management section in a couple chapters, but childbirth is a painful process for most women. There's a wide range of pain management methods out there that can be currently used for childbirth and labor. Healthy People 2020 goals related to cesarean birth in the United States. Well, let's look at this because the process of labor takes time, and there are many obstetric interventions that are widely used, like induction of labor, augmenting labor with Pitocin, giving an epidural that can influence the length of the labor process. Delaying the interventions and allowing labor to progress naturally will decrease medical interventions and decrease the C-section birth rate. So there's two goals that Healthy People 2020 have in relationship to cesarean birth in the U.S. The number one is to reduce the cesarean birth among low-risk women to 23.9% of live births from a baseline of 26.5%. So right now in the U.S., our C-section rate is 26.5%. That's the highest in any other country. We want to reduce the rate of cesarean births among women who've had prior C-section births to 81.7% instead of 90.8%. So these are repeat C-sections. We want to try and decrease repeat C-sections. To achieve the goals, patience during labor is required. Methods to increase patience during labor are to educate the woman and her family that every labor is different and it's difficult to predict how long labor will last. Avoid interventions like epidurals that can reduce the woman's ability to push and participate in the delivery of her fetus. Avoid induction of labor when the cervix is not soft yet, not softened enough, not effaced enough, so that it will be receptive to induction methods if needed. Avoid the induction of labor for convenience. That's definitely not recommended. Women who are induced have a significantly longer time in labor. Provide reassurance to the mother that the fetal well-being during the labor process. Provide non-pharmacological pain interventions as well as pharmacological support for pain during labor. If the fetal monitor indicates that the fetus is healthy, do not place pressure on the obstetrician or midwife to rush the birth. Allow a longer pushing phase. A longer pushing has not been associated with poor outcomes, but it does need to be monitored. A delivered placenta appears to be misshaped. What should this indicate to the nurse? Can you guess? Maybe the placenta supported twins, placenta was placed low in the uterus, placental fragments remain in the mother, or the placenta was malformed upon implantation. The correct answer is C. The placenta should be evenly and round. It should not have misshaped. It should not be chunky. If it's chunky like that, misshaped, then there's placental fragments that remain in the mother. And when we look at the postpartum section, we'll see why. Now let's take a closer look at the stages. There are 4 stages of labor. And in the first stage, there are 3 phases. The phases are a part of the labor process. In the first stage, we're having dilation. And during the dilation period, there's 3 phases. So you have early labor, also called latent, active labor, called active, where the woman is about 4 to 7 centimeters dilated. Transition is getting ready to push, but not pushing yet. And the second stage is when the birth of the baby happens. At this point, the mom's fully dilated and she is got the urge to push and she's pushing. The third stage is when the placenta is delivered. The fourth stage is recovery in the postpartum period. So first stage, dilation. Second stage, birth. Third stage, placenta. Fourth stage, recovery. So I put it in here like this. If you can repeat these and keep saying them, you won't get messed up when you're trying to understand the stages of labor. First stage is the cervical dilation. 3 phases, okay? Early or latent labor is the dilation of the cervix to 4 centimeters. So up to 4 centimeters is not that bad. The contractions are mild every 5 to 10 minutes for like a couple hours. They're so excited. You know, they can tell you about finally labor, you know, finally making cervical change, and they're feeling pretty good. Active labor is when it starts to become a little bit of hard work. So the woman is becoming more focused. Her sheer dilation when she's checked is after 4 centimeters up to 8 centimeters. So while I'm dilating, now usually the average dilation takes about an hour for 1 centimeter. So about every hour there may be a couple of centimeter or so dilated. And in this active stage, mom's focus, contractions are 3 to 5 minutes apart, and they're stronger. Maybe she's doing her breathing techniques now. She's starting to realize it's finally happening. Transition is anywhere from 8 to 10 centimeters dilated. The woman feels a little out of control because things are changing rapidly now. Contractions are very frequent, every 2 to 3 minutes. She is getting ready to push, but not yet. She feels the urge to push, but there's no pushing yet. We gotta wait, and we gotta make sure all the cervix is fully thinned out, fully effaced, and fully dilated before pushing can begin. They may be nauseous and very irritated, and then we're just getting ready for the baby to be born. So feeling kind of miserable at this point. So let's guess. A woman is 7 centimeters dilated using breathing techniques she learned in prenatal classes and has contractions every 5 minutes. What stage of labor is she in? First stage, active phase. So first stage is the correct answer. This should say phase, not stage. So she's in the active phase of stage 1. And the second stage is the birth of the baby. So the cervix is completely dilated to 10 centimeters. She feels more in control. Now we're starting to count and push, and it ends with the birth of the baby. So it begins with pushing, ends with the birth of the baby. So for the pushing time, the stage 2, the birth of the baby. The uterine contractions are every 2 to 3 minutes. They last about a minute to a minute and a half. Increased bloody show. They have some blood be coming out. The bear down and pushing is happening. The pushing stage can last from anywhere from 30 minutes to 90 minutes for a first-time mom, or very quick, much more quicker for multi-pairs. So people who have had multiple babies can be very fast, sometimes even quicker than 15 minutes. Techniques for pushing: closed glottis and open glottis pushing. So closed glottis is when we're going to have them hold their breath, and everyone else may count while she holds her breath and bears down like she's having a bowel movement. Open glottis pushing might be more of a gentle pushing where you're releasing some of the air out while you're pushing. It's not as strong as the closed glotted pushing. There are cardinal movements that the baby has. Sometimes they're called the mechanisms of spontaneous delivery, and it's the process of how the baby turns and maneuvers itself out of the birth canal. It's pretty awesome to watch this rotation of the baby as it's coming out of the birth canal. The first part of this is the engagement. So the fetal head enters the pelvis to the level of the ischial spine, so 0. Engaged at 0, level 0 of the ischial spines. Then it begins its descent, and that's the station of the fetus going down. So maybe they're at a +1, +2, +3. The baby's head is in a flexion attitude, so their attitude's in a flexion. Then they begin the internal rotation. So the baby's going to be twisting here. It's got to get those shoulders out, remember? So the head rotates 45 degrees to the anterior position, which is what we like. And however, if it's in a OP position, so if they are face up instead of face down, the backwards of OA, maybe if they're OP, then that is going to lead to back labor and prolonged labor and back pain because the baby's head is pushing on the pubic symphysis. Not pubic, but the sacrum area. Then after the head rotates, we have an extension. So the head is into the pubic arch and extends under the symphysis pubis. So they're rotating out, rotating their head, pushing out now. Then there's going to be an external rotation. After the head is out, the shoulders lines up with the head lines up with the shoulders then, so it's all straight now. And then it'll pull out one shoulder at a time, and that's the expulsion once the body is out. It's pretty neat to watch. Do you have to memorize every little step of this? No, you don't. Okay, so this is just nice to know not really need to know stuff. And then at the very final third stage, we'll wait a little while and then the placenta will be delivered. So when the placenta is delivered, there's a couple signs that lets us know that placenta is coming out. So baby comes out, cut the cord, and now we're going to wait on the placenta. So the delivery of the placenta is usually within 20-30 minutes after the delivery of the baby. The practitioner may give a gentle tug, but no pulling. That could create lots of bleeding. So just a gentle tug, and it will kind of encourage it to let go. So those vessels have to separate from the uterus. So the placental vessels have to close off and separate to come out. That's what's taking place here. So we know it's going to happen very soon. The umbilical cord lengthens. So as it separates, some cord comes out. There's a sudden trickle of blood at the vaginal opening, and the uterus will rise up. So the uterus will rise up because it's going to be contracting to push that placenta out. Sometimes we'll encourage the mom to give a push to get the placenta out. So it can be expelled in any way. It doesn't matter. There's the shiny side, that side that fetus was attached to, and the maternal side, which is raw and red. Of course, where all the vessels were connected. The placenta gets inspected after delivery to make sure there's no fragments left in. If a placental fragment gets left in the uterus, it can cause a hemorrhage or infection within the woman. So after the placenta is delivered, we begin massaging the uterus as soon as possible to minimize blood loss, or immediately. So here we are, the third stage, placenta delivery. Again, the cord lengthens, gush of blood, can take up to 20 to 30 minutes, and we also see that the uterus rises upward. And this is what the placenta looks like. Okay, this is the shiny side that was on the baby, and then the other side was the side attached to the uterus. Okay, so signs of placenta separating. Can you tell? We just said them. There's 3 of them. Okay. And your answers are trickle of blood, umbilical cord lengthens, uterus rises upward. And the final stage is the recovery stage. So after the delivery of the placenta, we start this immediate postpartum period. It's the first 4 hours. We monitor for complications. Number 1, bleeding is going to be your main complication. That's the main thing that is going to be wrong here. So we got to prevent, monitor, and treat this problem. Monitor for complications, bleeding. What do? Immediately massage the fundus. We massage that uterus so it can contract. Mom is talkative and may cry, be overwhelmed with emotions at this point. Postpartum shivering is considered normal at this point. There's been a lot of fluid shifting, and it creates the woman's body, makes it shiver a little bit. You can give them a blanket if they need it, but it's completely normal and it doesn't harm anything. So the 4th stage is done whenever the mom's vital signs are stable and everything is stable. Up to 4 hours is the 4th stage. At this point, we can expect the uterus to be firm. It should be firm. It should be at midline, so at the umbilicus, halfway or maybe a little above the umbilicus right after delivery, halfway between the symphysis pubis and the umbilicus. Lochia is heavy with bright red blood mixed with clots. We'll talk about what lochia is later. So bright red blood mixed with clots, mild uterine cramping, and after pains. So after pains is the same thing as uterine cramping or the uterus contracting still after the delivery, and that's what we want it to do. Some changes that happens within mom's body during labor. Whenever the mom is having a contraction, the blood flow to placenta decreases. We need to remember that. Our baby's not getting much oxygen during contractions, and we need to measure how the baby's doing during this time, and we'll talk about that during labor assessment. Labor also raises the blood pressure and decreases the pulse rate of the mother. We do not want our mom to lay on their backs. Laying on their back puts pressure on the vena cava, which restricts blood flow to the placenta. So if we put them on their back, they can get hypotensive, and that also will reduce placental blood flow to the baby. So we want to labor in a side position or sitting upright to avoid that. Mom's anxiety and pain can cause an increased heart rate and depth of respirations, and hyperventilation can occur. And we definitely don't want this to happen. So we'll have to help mom manage her anxiety and pain. Keep the mom's bladder empty, because a full bladder can weaken the contractions that the mom can have, and a full bladder gets in the way of the head descending because we need that space there. So keep mom's bladder empty. Have her urinate often. We don't want the bladder in the way. And that's especially true for after the baby is delivered. Also, mom's bladder needs to stay empty so that the uterus can contract down and clamp off all the bleeding blood vessels. During labor, mom's gastric motility slows down somewhat. All the focus is into the laboring process. Nausea and vomiting can occur during labor, and that's usually as a result of the pain and it's the hormones that are going on here. Now, blood loss at delivery is expected. The expected blood loss for a vaginal delivery is 500 milliliters. Anything over that is considered a hemorrhage. Because of the increased blood volume during pregnancy, most women have no adverse effects from this amount of blood loss. A hemoglobin of 11 and a hematocrit of 33 or higher indicates that the woman can handle the blood loss without problems. But anemia is defined as the hemoglobin level of less than 11 or hematocrit less than 33 in the first and third trimesters. The woman may have a high white blood cell count, and that's pretty normal, between 14 and 16, that's normal. And then the fibrinolysis slows down, promoting coagulation when the placenta separates. So there's some changes that go on to help with clotting afterwards too. So a woman is admitted in labor, and her hemoglobin is 12.6. The nurse knows that what? Patient has an infection, they may have problems with excessive blood loss, patient has normal hemoglobin, or patient is anemic. The patient has a normal hemoglobin level. So 12.6 is on the low end of normal, but it's definitely okay. She could probably handle the blood loss, but they will keep an eye on it afterwards. Which stage of labor is birth? So here we go. Try not to be too tricky. Good job. Second stage. The stage of labor when it is most appropriate to push is which one? Good job. The second stage is the birth stage when you are pushing the baby. For the baby side of how it responds to labor, there is an increase in the intracranial pressure, well, because of where the head is and the contractions. The placental blood flow temporarily is interrupted at the peak of all the uterine contractions, and it stresses the cardiovascular system. It may result in the baby's pH decreasing throughout the labor. So we want to make sure that any baby whose heart rate is not doing well with the contractions, we will put oxygen on the mom. Passing through the birth canal is very beneficial for the baby. It stimulates surfactant production. Surfactant is what keeps our alveoli open in the lungs. It's a product that the babies need in order to breathe effectively after delivery. And it helps to clear respiratory passageway. So they get that good squeeze through the birth canal in a vaginal delivery, and it helps clear the passageways of amniotic fluid and mucus production so the baby can take good deep breaths when it's born. So with the swelling on the baby's head, there's a couple of different words here that we need to learn. Ecchymosis just means bruising on the baby's head. Edema is the swelling. Caput succedaneum. Caput succedaneum is the picture on the right here, and you can kind of see the indentation of the of where like the baby was sitting and the cervix was squeezing while during contractions on the baby's head. So that's pretty cool there. Now I like to call, you can put a cap over it because it crosses the suture lines. So it's like on the equal side of the baby's head. Whereas a cephalohematoma is a blood collection or a big blood bruise collected on one side of the suture line. So it does not cross. Yeah, this baby has a little horn on the side. So that one is a cephalohematoma. So that's how you can help determine the difference between the two. Caput crosses the suture line, and cephalohematoma is on one side or another. The fetus also experiences labor with the mother. In a healthy fetus, there's no adverse effects from a labor. The heart rate changes in response to labor. So whenever the baby has contractions, the baby should have some accelerations during labor and have some heart rate changes. It should not be a steady heart rate, so it kind of bumps up and down. They'll have decreased circulation and perfusion during the contractions. They may have an increased arterial carbon dioxide pressure, a decreased fetal oxygen pressure, and a decreased fetal breathing movements. Now, these are nice to know, but not anything you need to memorize for this lecture. Let's take a look at these questions. The nurse is describing true and false labor to the patient. Which of the following statements made by the patient indicates that she understands the difference? Okay, would the woman understand if she said, a false labor contraction usually starts in the back and radiates around to the front of my abdomen? True labor contractions cause cervical changes. True labor contractions will go away with a warm shower. False labor contractions get stronger if I take a walk. True labor contractions cause cervical changes. Look at the next question. The shortest stage of labor usually is the pushing, transition, active, or latent. Now, I didn't say which one was the shortest, but what is your guess? Right, transition phase. The pushing phase takes anywhere from 30 minutes to an hour or longer for primogravidus, and then multipares are 15 to 30 minutes.